Okay, it's 12 o'clock, so we're going to start. Want to welcome everybody to Pediatric Grand Rounds. Today, we're going to have Meredith Russell introduce our speaker, so I'll hand it off to Meredith. Meredith, are you able to hear me?
I
Perfect.
am, thank you. I'm very excited to introduce Dr. Steve Gittleman. Stephen Gittleman is professor of pediatrics and director of the Pediatric Diabetes Program here at the University of California, San Francisco. He received his undergraduate training at Princeton University, medical school training at the University of North Carolina, and completed his pediatric residency and endocrine fellowship training here at UCSF, where he has been ever since, to our delight. He holds the Mary B. Olney MD KAK Distinguished Professorship in Pediatric Diabetes and Clinical Research. He is a clinical trialist attempting to find safe and effective means to preserve beta cell function in type 1 diabetes. He is a clinical center director for the NIH-sponsored consortia TrialNet, an investigator in the Immune Tolerance Network, and works closely with industry partners. It is my pleasure to introduce Dr. Gittleman, who will discuss his groundbreaking research altering the course of type 1 diabetes, the journey with Teplizumab.
Thanks, Meredith. It's a pleasure to be here, and I'm glad we're getting some nice endocrine flavor added to Pediatric Grand Rounds. So I'm going to tell you about this, the challenge with type 1 diabetes, and then this journey with the drug that rolls right off the tongue, Teplizumab. And I'll start with my disclosures. When I was in training, if you showed any connection with an industry partner, it was like you had a scarlet letter or something. And I think for the kind of work I do in clinical trials, industry often has the reagents we need to do these studies. So I'm actually proud of the partnerships. I'm glad that industry wants to talk to me. I certainly want to talk to them and see what possibilities we might have to explore together. And I think you'll get a flavor for that during the course of my study today. So I serve on some advisory boards for some of these companies. I think the most relevant for today is this company, Prevention Bio, that was sponsoring the trials that we've been involved with, along with the NIH. And I serve on some drug and safety monitoring boards that oversee some of the clinical trials in type 1 diabetes. So I'm going to give you a background in type 1 and why it's such a clinical challenge and why we need to do something to better understand and manage this condition. And then really walk you through this journey with this particular drug, Teplizumab, which I think highlights some of the challenges, but also the joys of working in clinical trials, and then end with some just thoughts about where we're going in the future here. And wherever you sit, you can't help but hear the news about what a challenge diabetes is these days. It's increasing around the world. The burden to the individual, to society, is just unprecedented for chronic illness. And so we're in trouble here. And so it's a condition we really have to understand better. Just to highlight some of the impact here. So currently, just by the rate of change, the slide's already out of date, I'm sure, but an estimated 537 million people in the world with diabetes, with a projection of 783 million by 2045. It now affects about 37 million in our country. About 5 to 10% have type 1 diabetes, which will be the highlight of my discussion today. And of course, if you don't manage this disease properly, there's tremendous issues with morbidity and mortality. So it's the leading cause of blindness in adults, the most frequent cause of end-stage renal disease, most common cause for limb amputation, up to a 5-fold increase in coronary artery disease, and traditionally a shortened lifespan by as much as 10 to 20 years. And in this day of budget discussions, this is a huge economic burden as well. So diabetes now accounts for $327 billion annually in total healthcare related costs. It's now 1 in 4 US healthcare dollars, and it's increased 41% in 5 years. Quite a burden for all of us. Okay. And as many of you know, we think about two main forms of diabetes, type 1, which used to be called insulin-dependent diabetes or juvenile onset dependent diabetes, contrasted with type 2 diabetes or non-insulin dependent or formerly known as adult onset diabetes. And it looks like there's this nice, neat distinction between these two forms, with type 1 resulting from beta cell destruction and insulin dependence. But it turns out the more we study these two conditions, we realize there's certainly some overlap, and they're not quite as distinct as you might have thought. So for instance, type 1 diabetes can occur at any age. New onset diabetes, about 40% is in new onset is over 18. We used to think of it as this catabolic disorder where individuals present very lean, but in this day of obesity, about 25% of new onset type 1 individuals are overweight or obese. If we make a diagnosis early, they don't necessarily end up in ketoacidosis. By contrast, in type 2 diabetes, some of these individuals do have antibodies and kind of a mixed picture of type 1 and type 2. And I think the most telling issue for type 2 is it's not just an adult condition. So more and more we're seeing new onset pediatric type 2, usually in those who have entered puberty. So one of the hallmarks to help distinguish these two is the presence or absence of autoantibodies, and I'll talk a little bit more about that. So as I was mentioning, this is autoimmune destruction of insulin-producing beta cells. Here's a histochemistry slide of that lymphocytic infiltration. And it's amazing the havoc that this can wreak. Just the destruction of a single cell type, and it's just hard to replace that missing cell function. So, I think for those not directly involved in endocrinology or in the lay public, people wonder what the big deal is with diabetes. It's about 100 years ago that insulin was purified by Banting and Best and first used in a clinical setting, and we thought the cure was here. And there are, of course, lots of nice different insulin formulations. This is also in the news a lot now because the cost of insulin has skyrocketed so much and it's limited availability for some people. So you might think we've solved the problem. And in fact, about 30 years ago, this landmark study came out sponsored by the NIH called the Diabetes Care and Complications Trial. And it was very exciting because it showed for the first time that if you had near normal blood sugar control, you could minimize or eliminate the risk from some of those long-term complications. So we thought we were well on our way to dealing with this particular disorder. But it turns out, it's much harder than we would have thought to keep blood sugars in a near normal range. And this is a slide that many of us show that highlights the struggles of clinical diabetes management. This is from, we don't have a registry for type 1 diabetes in the US, but this is from a consortium of about 50,000 patients from the top diabetes centers around the country. And so it's not fully representative, but what was done was they took a hemoglobin A1C measurement as people entered this registry at various ages. And if you just look at the red curve here, so this is 2010 to 12, and you can see the A1C at a given age from age 1 or 2 out to 80. And in dark blue here, this line is the recommended goal for hemoglobin A1C, a 7 or an average blood sugar of 150. And you can see at any age, people are well above that mark. And in fact, this analysis was evaluated again 2016 to 18 as tools like sensors and pumps have been used more commonly. And you can see that this curve is even worsening. And one thing you can highlight here is adolescence, which is a particular joy for all concerned. I have 3 adolescents at home now, so I can speak from experience. So this highlights our trouble. And as a result of this, um, we've tried to figure out how to best replace the beta cell. And the beta cell, it senses blood sugar and releases insulin in this very carefully regulated function or manner. But it turns out it's hard to mimic that closed loop. So you can use clinical symptoms or glucometer. You can now use this continuous glucose monitoring device. We can deliver insulin in creative ways, such as by pump or inhaled insulin or the traditional means with injection. But it's hard to close the loop in a fully functional way. Not that the engineers aren't trying. So as a result, with so many people not able to achieve the glycemic goals, we still see the problems from long-term morbidity, mortality, as well as acute risks, such as severe hypoglycemia or ketoacidosis, and concerns about mental health with issues such as depression, substance abuse, suicidal gestures, and very risk for mortality, even in younger populations. So yeah, that keeps all of us up at night. The other thing that bothers us is the incidence of type 1 is increasing over time. And this is seen across a variety of different countries here. Again, we don't have a registry in the United States, but we have some regions that track this very carefully, such as in Colorado. And so it's increasing, particularly for those under age 6, 3 to 5% per year, increasing the incidence of type 1. So the burden of type 1 in our country and around the world is going to continue to increase. So, you don't have to go to clinic too often to really start to wonder, why can't we better understand what's causing this and do something to alter this course of disease? So let me tell you a little bit about our road ahead here. So part of this is to look at the genetics of type 1 and better understand how that leads to cause of disease. And this is not a simple monogenic story in the majority of cases. It's involves over 50 different regions in the genome. The highest risk, not surprisingly, with an autoimmune condition is in the HLA locus. That's thought to confer about 50% of the risk, but a number of other genes involved across pathways that you might expect, such as immune pathways and metabolism. When you think about genetic risk, you can start to look at identical twins, of course, to look at the underpinnings of disease. And the identical twin story with type 1 is particularly interesting. In more historic studies, if twin A had diabetes, twin B had a 30 to 50% risk. It turns out if you follow them long enough over time, they do become concordant, but it might have to be a follow-up of up to 70 years or longer. So if it's not all genetics, then of course you can wonder about environmental contribution. There are a lot of very interesting epidemiologic observations. It turns out the risk for type 1 and other autoimmune diseases is higher as you move towards the poles. If you immigrate from a region of lower risk to higher risk, you assume the risk for your new locale. There's a seasonality to type 1 new onset presentations, often higher in the fall and winter. We certainly see clusters, outbreaks that suggest some infectious agent might be underlying this. And there's very interesting research about particular classes of viruses, such as enteroviruses, and the role that they might play. There's also a question about obesity and whether that might accelerate presentation. And then questions about the hygiene hypothesis and whether, if you're not exposed to some of the usual pathogens and things early in life, if that could predispose you to an autoimmune response. So very hard to prove environmental cause, but certainly some suspects there. So how do we put this together? So in thinking about progression to type 1, we think there's a synergy between the genetic risk that you assume when you're born into a particular family and these environmental triggers. And over time, you'll start to move towards beta cell destruction. And so the question has been, how can we visualize that? You can't image the pancreas, you can't see the beta cells or these small clusters scattered throughout the pancreas. And so a very important tool for us has been autoantibodies. And so we can now measure within the blood up to 5 of these. And basically what we've learned from birth cohort studies following children over time is that you can see the appearance of these early in life. And if you develop 2 or more of these, your risk for progressing on to diabetes is pretty high. So that by 10 to 15 years into that time with multiple antibodies, you've converted to clinical diabetes. So it's a helpful marker. We don't think these are causing diabetes, but they're a helpful marker of the process that's going on behind the scenes. The other thing we can look at is what about metabolism? It wouldn't be surprising as you're getting further down this path towards diabetes that you might start to see some metabolic abnormalities. And so the most sensitive marker for us is an oral glucose tolerance test. And so if your OGTT is normal, but you have multiple antibodies, your rate of progression is relatively slow compared to those who have some abnormalities on a glucose tolerance test, but are not yet in the diabetes range. So we can start to use these different pieces of information in a way to better put together this roadmap. And this is a review that really starts to put this staging into perspective. And so I'll show this map further with a little bit more detail. So basically what we've learned is we think that the onset of diabetes is really before elevation in blood sugar, is what we call stage 1. You have 2 or more autoantibodies. Your oral glucose tolerance tests are normal, but we know that eventually you're most likely going to develop clinical disease. Stage 2 is when you have some of those abnormalities on the glucose tolerance test, but not yet needing supplemental insulin. Stage 3 is what you're used to calling new onset diabetes, when you need to introduce insulin. And stage 4 is longer standing diabetes, where there are no remaining beta cells there. And so with this paradigm in mind, you can start to think as a clinical trialist and think about where you might intervene. And so we could come in upstream, try and screen and predict who's going to get diabetes and try and prevent it from happening. Or you could step in shortly after diagnosis and try and preserve the beta cells that are there. Or you could come in later at stage 4 and try and replace them. And what's been very exciting in our field is there's great work going on across all these different stages. And I'm going to tell you a story that deals more with the prevent and the preserve aspect of this. But replacement strategies are definitely coming and would be a great discussion for future grand rounds. So if you step back and think about these approaches, there's some pros and cons of what stage you step in, and it kind of challenges us as clinical trialists in our study design. So we could come in really early for someone way up on that curve who might not yet have any antibodies, but might be at genetic risk. We're not sure if they're going to move down that curve, so we're probably going to have to conduct a larger study over a longer period of time, but we might be able to come in with a pretty mild intervention like a dietary change or an antigen-based therapy, and it might work. If we come in later on that curve, say at stage 2 or stage 3, we already know who has disease or who is very likely to get disease, so we can probably do a smaller study over a shorter period of time. But because we're coming in later, we're going to have to dare to be a little bit more aggressive and accept some potential safety issues as a result of that. So I will tell you that as of 2018, and with my time in this field over a couple of decades up to that point, there've been some interesting efforts. So we conducted a small number of these large, well-designed prevention trials. And we usually focused our recruitment on unaffected family members who had someone with type 1 diabetes, because we knew they were at least 10 to 15-fold higher risk, but overall they would have about a 4% risk of eventually developing type 1. And you can imagine it's not a very efficient way to find the at-risk participants. So for any of our given studies, we might have to screen up to 100,000 relatives to find a few hundred that could enter a study and then follow them for years. Pretty inefficient. So the studies that we conducted in those preceding decades, they all had solid rationale. They were based on preclinical studies that looked very promising, epidemiologic observations, often smaller pilot trials. But the problem was none of them worked. They were all negative, despite our best efforts. And of course, the wise guy in the back of the room would say, well, I guess you just haven't done the right studies, have you? And I think the field wasn't quite ready for more aggressive immunointerventions. We really focused on safer therapies, often antigen-based or dietary therapies, and they just didn't work for a variety of different reasons. So the field shifted. And as I got more involved, our attention shifted really towards stage 3. So I'll just talk a little bit about some of the reasons for stepping in at stage 3. So, basically what we're hoping to do is extend this, what we call the honeymoon phase or the remission phase. So at the time of clinical diagnosis at stage 3, you may have up to 15 to 40% of beta cell mass remaining. And if you went to medical school when I did, you usually were taught that didn't last very long, weeks, maybe months, that would be it. So it turns out the more we study people, the more we've found in a variety of settings that people can maintain those beta cells for much longer than we would have thought. So it suggested that we had a window where we could step in and try and preserve things. And the other thing that we learned from studying people in clinic was even if you had to take supplemental insulin, having that undercurrent of beta cell function could make a big difference in your clinical management. You tended to have better blood sugar control with lower hemoglobin A1C, less swings in blood sugar, less risk for severe hypoglycemia, less risk for complications. And most importantly to the work I'm going to talk about, if something works in that stage 3 new onset space, we can take it upstream and use it for prevention in theory. So not a new idea, this idea of stepping in at stage 3. In fact, in the 80s, there were a whole series of studies with some broad immunosuppressants. Those are the reagents at the time, things like cyclosporin. And the general experience was they worked. It showed proof of principle that this was an autoimmune disease, and if you suppressed it, you could preserve the cells. The problem was, these were broad, generalized immunosuppressants. You had to use them continuously. Not everyone responded, and there's, of course, risk from the potential toxicities. And so again, the field was on hold, waiting for better reagents. And so fortunately, our drug company partners have come along with things for us to consider. And so now I have the privilege of sitting at some different tables to plan these trials with different groups. And we often look for drugs that might work in a preclinical model. Maybe they've been used in other autoimmune diseases or transplant. They might have even been FDA approved in those settings. We'd want them to have a plausible mechanism in type 1 diabetes. And we think this is mainly a T cell mediated disease. So we wanted to target T cells. They, of course, have to be reasonably safe, given we have therapies for diabetes already, just challenges. And the ideal thing would be if we didn't have to use that heavy-duty continuous immunosuppression, if we could give it for a brief period of time and withdraw it and fundamentally change the immune response. So that's the wish list. And just stepping back and thinking about this pathway for drug development, this is a daunting task. And you've probably heard enough about this over the years to understand there's many attempts to explore things in a preclinical setting and bring them forward into clinical trials. Even when you enter clinical trials, it's only a small percent that make it successfully through phase 1, 2, and 3 and out into approval. So it might take on average about 10 years at a cost of about $2.5 billion. So this is not for the faint of heart. It's also interesting to look at which fields drugs are being approved in. And this is by class, drugs that have made it from phase 1 to approval over the past 10 years. And you can see in darker blue here, there's a lot in oncology and in neurology. And for me and my colleagues in endocrinology, we're a small part of the pie, even though we have such a huge issue with diabetes, as I mentioned. So we need to get busy. So let me tell you now about this journey with one particular drug, Teplizumab. And I'm focusing on this in part because it's the one I have the most experience with and is, I think, kind of a singular UCSF success on many levels. I think it kind of highlights some of the challenges that lie ahead, but it's also a success story as well. So it's fun to share it with you. So let's go back to some very crude thoughts about what causes type 1 diabetes circa early 1990s. And I mentioned we think that this is caused by autoreactive or T effector cells. We all have potentially autoreactive T cells that escape thymic selection or out in the periphery, but nothing happens unless they get activated in their interaction with antigen presenting cells. One thought that Jeff Bluestone and colleagues, including Dr. Hirsch, had was, why don't we try and find a drug that can just interdict this conversation and keep these cells from getting activated? And so one way to do that would be something to block this primary signaling between the HLA and T cell receptor and use a monoclonal antibody against a component of the T cell receptor, the anti-CD3 monoclonal antibody. So you'd first want to look at this in a preclinical setting, and that's what they did. And so let me introduce you to the main preclinical workhorse in type 1 diabetes. That's the non-obese diabetic mouse. So it's a single mouse strain. It kind of represents an N of 1 in the clinical world. But it turns out if you're a female NOD mouse, you don't have a very happy life. By about 15 to 20 weeks of age, you've developed lymphocytic infiltration of your beta cells and diabetes. And so it turns out people have explored lots of therapies in the NOD mouse. If you give things early in the course of the mouse's life, in the first few weeks, many things can prevent diabetes. If you look later in this time period, beyond 12 weeks or shortly after the mouse has developed diabetes, it's very few things that can block it or reverse it. So I'll just introduce you to the treatments here with this monoclonal antibody. So here at 4 weeks, you can see that both the control in the open circles and the drug-treated group in the black circles progress on to diabetes as I outlined. Most have diabetes by 15 to 20 weeks here, or maybe a little bit later in this colony. Similarly, at 8 weeks, a little bit better at 12 weeks. You might start to see some delay in the treated mice getting diabetes. But if you treat mice shortly after the onset of diabetes, so 100% have diabetes, those getting control vehicle basically have diabetes and keep it. And those who had diabetes go into a lasting remission, even though they only had a few doses. And if you look at the islets, you convert them from this heavy lymphocytic infiltrate to clearing functional islets, making insulin. So that was powerful. And this was about the time that, so highlighting that block. So for me, this was a very fortuitous time because Jeff Bluestone moved from University of Chicago to UCSF. And shortly after he did so, he called me up as the director of the diabetes program and said, I want to see if I can get you involved in this. And shortly after that, Kevin Harold called me as well, and we started to get involved in the studies. So these have been my main 2 partners in this aspect of diabetes for a number of years now, and it's been a very exciting adventure. One thing I learned from all this work is you really have to pay attention to who the authors are in some of this work. And I just have to call Rafi out because he was working with Jeff very early in the course of this and has quite a few publications about the CD3 story, and then came to join us later. So just a few words about this drug. It turns out the first approved monoclonal antibody is OKT3, and this drug is derived from this. So 1986, Um, Jeff modified this in some clever ways so that it would be better tolerated. So humanized some of the IgG backbone, and then changed the FC portion so there'd be less of an issue with cytokine release. So this was the drug that was taken into clinical trials. And it's always hard to jump from the experience in mice to man, but they came up with this 14-day regimen, daily IV for 14 days, starting at low dose and ramping up over a few days to get to the therapeutic dose. And there was an initial study on renal transplantation that looked well. And because of Kevin and Jeff's interest, they moved it right over into diabetes. And it started as this small phase 1/2 trial. 12 got treatment and 12 were observed. And they were enrolled shortly after diagnosis. And the goal was to see how it affected the beta cells over time and get some sense of safety. So I'll just introduce you to our measure of beta cell function. We basically have people come in before breakfast, they skip their morning insulin, and we give them this delicious treat that you can buy at Safeway called Boost. And this is called a mixed meal tolerance test because it has protein, carbohydrate, and fat, and it's thought to maximally stimulate insulin secretion. And we measure the metabolite of insulin, C-peptide. And so you get your boost, and then at interval times, we measure the response, and we look at this area under the curve as our measure of function. And so I'll just show you the data here. And so this is what we call the C-peptide area under the curve, that measure I just showed you at baseline, and then a year later in the drug-treated group versus the control group. And your eye can kind of pick up the story here. Most people in the treated group are stable or increase, and most people in the control group decline. And I'll show you this graphically. So in black, again, are the drug-treated group and the placebo group. And so that was a New England Journal publication, very exciting, and we thought we were on our way. We looked a year later, and looks like the effects were off, right? The drug-treated group stable out to 1 year, but now it's slipping, and it looks like, this is just frame shifted out from the placebo group. So it looks like maybe the brakes came off of the process. So we moved into, the next stage of this would be a phase 2 study. Oh, I meant to tell you, what was also gratifying was there was another group. There are other companies that have developed related anti-CD3 monoclonals. This is one used in Europe, Teplizumab, and another New England Journal paper, similar effect, showing the drug-treated group maintained their beta cell function better. So that was exciting, supported our results, and we moved on to a phase 2 study. This one was supported by the NIH, the Immune Tolerance Network, which has supported a lot of the work here. And so in this study, instead of giving one 14-day course, we gave 2 doses to try and extend that response, one at baseline, one a year later. And here are the eligibility criteria, a little bit bigger study. One of the challenges is hard to blind studies when you're giving 14 consecutive days of a treatment. So it was an observation group. Here are the results of this one. Here, the primary endpoint was at 24 months instead of one year. Here are the treatments. In green is the placebo group, in blue is the treated group. Here's a really nice p-value. What do you guys think of that response? It's a little bit underwhelming, isn't it? I mean, it looks, there's this initial stabilization, then decline, it looks parallel. We did some further post hoc analysis here, and it turns out about half of the drug-treated group, shown in blue here, looks very similar to the placebo or the control group. They just didn't seem to have an effect, whereas the other half had a pretty nice, robust effect and very similar out to 24 months. So again, we were excited. We're moving on. The next stage in drug development, of course, is phase 3. And it's the idea of go big or go home. The go big is let's enroll a lot more people in and see if we can reproduce this result. And so this effort moved to industry, and it was called Protégé. And the study was designed a little bit differently. And so this is where things start to go off the tracks a little bit, but I'll walk you through it. So in this case, instead of looking at the primary endpoint is that C-peptide area under the curve, the company realized that the FDA really wants to see some clinically meaningful endpoint. And so they shifted and adopted a composite endpoint of hemoglobin A1C and how much supplemental insulin use you needed, or hemoglobin A1C change, and then some other measures. And they ran the study. And the study was actually interesting design. They actually looked at some other ways of giving this, either lower doses or shorter regimens, and they repeated it at 6 months instead of 12 months. This involved, over 500 people, so it was go big. And the other thing I should mention is because they wanted to enroll the study, quickly, they went to other places around the world. So US was about a third of the enrollees, about a third from Europe, but many of these were Eastern Europe. And then India factored heavily in this study. And so, there's questions about the nature of diabetes, the background genotype, clinical management, how early people are diagnosed. So it started to add some additional variables into this. So, after all the work and looking at the data, it turns out those primary endpoints weren't met, and very disappointing. It turns out if they had used that C-peptide area under the curve measure, they would have met the endpoints. And if you looked at subgroups like children enrolled in the US and younger children, those that were just in that traditional 14-day infusion group, they would have met the endpoint. So there were just issues in part with that endpoint and trying to anticipate what the FDA would want to see to approve it. And it turns out how you use insulin varies according to your personal habits and your physician. And so, we felt that there were just some flaws in this. And then I've already mentioned some of the concerns about the patient population maybe being different. So it's kind of like the air coming out of the balloon now, isn't it? It sounds a little depressing. It turns out it's very challenging to show a difference early in diabetes between a drug treated and a placebo group because many people do well during that time when they still have some beta cell function. So we had to worry about money at that point. So as I mentioned, the Immune Tolerance Network, sponsored by the NIH, funded that promising phase 2 study. This shifted to companies. It was hard to find companies that wanted to continue this work. And then there's a question about that other drug in Europe. So they also conducted a phase 3 study, but their focus was on minimizing side effects. So their next study, they used a 15th of the original drug dose, and they completely eliminated side effects and they completely eliminated efficacy, unfortunately. So we thought this might just fall off the tracks and not make it. And so one of the clever thoughts was, why don't we turn to prevention? So let me just tell you the prevention saga. And the idea is basically if something is safe and effective at stage 3, which we thought it was, what about shifting it upstream? And could we treat an at-risk group and more easily show to the regulatory agencies and ourselves that it makes a big difference in the clinical course? And this is something that we tried to propose 23 years ago. And I kind of felt like Mr. Smith going to Washington, really excited with our first NIH grant to try and pitch this. We had an extensive discussion with our type 1 diabetes consortium, and basically people just weren't ready for this quite yet. They didn't really believe our smaller phase 2 studies. They weren't the classic, blinded trials, and not quite ready to be this aggressive. So after lots of discussion and writing and things, we had to wait. And basically the field shifted and evolved. And fortunately, 2010, we did have a chance to run this prevention trial. And it was a tricky study. We decided to do it as just 2 arms, drug treated versus placebo. And we decided the placebo group in this case, because of the prior critique, would go through all the same procedures. So you can imagine if you were the parent of a child and considering a study, would you want to do this? 50-50 chance that they could be having an IV and getting infusions for 14 consecutive days and getting placebo. The study was open to people who were at stage 2. So remember, multiple antibodies, abnormalities on glucose tolerance test, very high risk of developing diabetes in the next 5 years. And so here's the study. So this is called TN10. I think one thing to note is our ability to enroll in this study. As I mentioned, it was a tough sell. And you can see we started in 2011 and we completed enrollment 7 years later for 76 participants. So it was a long, slow slog to find people. Here are the results. And so this is a Kaplan-Meier curve. This is the percent without diabetes over time. In black is the placebo group. And you can see basically by 5 years, most had diabetes, 20% did not. Here's the drug-treated group. You can see that the curves dissociate pretty quickly. Remember, a single 2-week treatment and then nothing. And so where we are now with serial follow-up is this translates into a median delay in diabetes of 3 years. And now 12 years into the launch of this study, about 12% of the placebo group are free of diabetes. 34% of the Teplizumab treated group are free of diabetes. So it's pretty striking difference. And remember, it's that single 2-week treatment. So we were excited, and this had some nice prominent publications, again in the New England Journal for one. But our real question was, what does the FDA think about this? Is this enough to get a drug approved for standard clinical use? And it was a contentious discussion with the advisors to the FDA. And they mulled it over for a while. But we had those study results in 2018. And most of the time, the FDA likes to see multiple studies, usually 2 phase 3 studies before they approve things. This was a single 76 participant study. We didn't think we could do this again. How would you get someone to engage in a repeat study to come into a placebo group when we already thought we had achieved this efficacy? Was the 3-year delay enough of a robust effect for it to be approved? What do the regulators think? What does the families think of this? And then we had to share a lot of the long-term safety data, which fortunately looks very clean. So the reason I'm telling you all this, of course, is this was approved about 6 months ago. Big news for us. Prior to this, the only approved drug to treat diabetes is insulin. So this really, we felt was incredibly exciting. So we celebrated for a few minutes and then realized, well, the work's just starting now. There are lots of important questions to ask from this point. First of all, as you might have gathered from some of the slides I've showed you, some people respond really well, but some people don't seem to respond. So it'd be nice if we knew a priori who were responders or shortly after treatment who was going to be a responder. Maybe we could only treat those most likely to respond. We used to think, early in the course of this, that this drug was depleting T cells, but we do see a sharp decrease in lymphocyte counts, but they bounce back up pretty quickly within a couple of weeks of the initiation of treatment. And so we've been searching long and hard to see if we have surrogate measures of the immune response. It turns out one of them now that looks pretty promising is this partially exhausted signature from CD8 cells. But what's interesting is, that's present maybe for 6 to 12 months after an infusion and then disappears. And yet we're seeing long-term effects with this drug. So I think we still have things to learn perhaps about regulatory T cells here. What else could you consider? Remember when I told you about my concerns about the incidence increasing, particularly in younger children? These studies were done with the youngest age of 8. So we really need to now move into younger children. I think that could really be remarkable if we could keep them from getting new onset diabetes. In the stage 3 space, I told you that we were starting to give repeated courses of the drug, 2 courses. In this prevention trial, we gave a single course. So maybe a second course will help extend that effect. The more we study diabetes, the more we realize the complexities of this. So coupling it up with another drug that has some additive or synergistic effect will be great. We're debating long and hard about what is that best other drug, how might this impact the efficacy and safety, and ultimately, how do we bring additional drug companies to the table to share in this with us. Some other thoughts. If you'll recall, I told you that 90%, and I didn't tell you this. So it turns out 90% of new onset type 1 occurs in families with no family history. The studies that I told you about were in families that already had type 1. So it suggests that maybe now is the time to start screening more broadly for risk for diabetes, and there are efforts underway there. You could ask about using it earlier. I told you about studies at stage 2. What about stage 1? They progress more slowly, so we'd have to do a larger, longer trial. We don't know if there's a particular window where this drug might work best, where there's a time of kind of an immune flare. And then what about the new onset story? Remember, we started in on some studies there and abandoned that. It turns out in the past few years, we have gone back to another phase 3 study focused just on children, and we'll have those results in the early summer, and I think those look very promising. So, it's exciting for us that this was approved, and we thought we'd have a nice line out the door for people waiting to get their Teplizumab infusions. And families are fairly circumspect about this. One is, the 14 consecutive days with the IV is a challenge. So it'd be nice if we had easier ways to give this. The question of how to give it, we usually place a pick for this. A lot of concern about the risks. I'll just tell you quickly in passing that it is very well tolerated. There are usually some mild flu-like reaction with skin rash in about half. A small percent may have a cytokine release syndrome that's a little more notable, in which we stop the infusions, but no longer-term concerns, fortunately. There is a cost, and the drug company has priced this at about $2,000 for the drug alone, plus the associated costs. So insurance companies are considering this and starting to support this, fortunately. And I'd be remiss if I didn't tell you that, the more we think about this, the more we realize, gosh, there are lots of other reagents that we could consider in this pathway. The pathway, as we study it, is more and more complex. What axes we might want to target. Shown in red here are many drugs that have been used in the past 10 or 20 years, some of which have also been successful in new onset diabetes. So I think it's an exciting road ahead. And here's a review just summarizing some of the punchlines for what seems to work. So particular cytokine blockade, for instance, TNF alpha blockade, inhibiting T cell activation. Interestingly, B cell depletion seems to help, and we think that's because B cells can act as antigen presenting cells. Things that enhance regulatory T cells or promote T cell exhaustion, and things that support the beta cell are also in play. So I'm going to wind up here. I don't want to get too political. I hope I've convinced you that there is some positive change that we can affect here. And I hope ultimately that we can keep beta cells great. I'll just summarize by telling you, I think we really are at the end of the beginning with these efforts. I think to be in clinic, and to go to diabetes camp, we just really appreciate what a challenge this clinical condition is. We can certainly screen and predict those at risk. The approval of Teplizumab is very exciting in its use at stage 2 and delaying the disease onset. I think I've outlined a number of immediate important questions, and hopefully we'll find even more robust, durable ways to interdict this process. And I think this has very real implications, not only for type 1 diabetes, but other autoimmune diseases, transplant, and even other fields, and is an interesting paradigm as well for drug discovery. And I'll just end by acknowledging the great team we have at UCSF that does this work. Mark Anderson, who now leads the Diabetes Center and is head of the Immune Tolerance Network. Tremendous interaction with Jeff Blueston over the years. Srinath Sanda in our division and also works in the Immune Tolerance Network, has been very supportive. We have a great group of study coordinators who are very busy with this work. And I've had a very nice partnership with Kevin Harold over the years at Yale and been fortunate to have funding from a number of different organizations that support this work. And if you want to refer anyone to us, we're happy to talk to them or their respective family members, either with new onset diabetes or those who might be at risk and want to get screened. So I will stop there and be happy to take questions from the live studio audience or anyone on Zoom.
I have a question that might be really dumb, but I'm going to put it out there anyway. It's never totally made sense to me that you give anti-CD3 antibodies for 2 weeks, and then you have a year long of effect without actually any side effects, because you're not preventing other T cells that do useful things from being affected by your anti-CD3, right? So why do you have a long-standing positive effect and not long-standing negative effects?
Yes. So just to repeat the question. So Sandrine's asking, why do we see, we certainly see some short-term effects, but why the longer-term benefit and not longer-term side effects? Yeah, I think that's part of underlying the question of, why is there a longer-term benefit? And as I was alluding to, I don't think we quite know that answer. And, this is a T cell monotherapy. It does target, most all cells have this CD3 receptor, so it's going to target T cells in a non-selective way. I think we don't get into trouble because of that just short-term impact. So that phase 3 study, new onset study I mentioned, we actually enrolled that steadily through COVID. And we followed kids very carefully. They all had to be vaccinated and, follow public health measures. Some of them got COVID. Some of their family members got COVID. No one got into trouble. They cleared COVID. They clear other infections very well. So we think of it more as an immunomodulatory agent rather than an immunosuppressive agent. The other arms of the immune system are intact. Ultimately, I suspect we still haven't delineated the underlying mechanisms, but it's, I think at its core, and Rafi can certainly comment on this, it's delivering a partial activation signal here that is resulting in kind of this exhausted signature. So it seems to be hitting more of those activated CD8 cells as the primary effect. And, naive cells and other cells can come in and do their job as needed. But I think ultimately, it's probably the regulatory cell population that's impacted, and we just can't see that because we can't get in and visualize what's happening in the pancreas. Want to elaborate any further, Rafi? Any other comments or thoughts?
I would just add that he's not activating anti-CD3 antibodies. Use the energy cells when it returns to it, and the energy can be very long. And maybe that they have more of a effect on T cells that are seeing the antigen.
Yeah, that makes sense.
But the other thing is, what's been observed with.
I don't know if we have a microphone so that the people online can hear it as well.
But with the number
oh, they can hear it? Okay.
Number of monoclonal antibodies that target various immune mediators, whether it be T cells, B cells, anti-TNF, other cytokines. Initially, it was a big surprise, to your point, that there wasn't more side effects and more immunosuppression, because people thought with the first anti-TNF therapy, it's the same thing. You wipe out TNF, everybody's going to get cancer, they're going to get viral infections, etc. And it turns out they didn't. And I think it just speaks to the redundancy of the immune system. There's so many different overlapping immune components that can wipe out one piece of it, and there's enough redundancy that the body handles it pretty well, surprisingly.
But I think your question also highlights our challenge, right? It'd be great to come in very targeted and only, modify the response that's impacting beta cells. And there are efforts there. There are things like, CAR T, CAR B like efforts, given that we know the antigens involved here. Those are hard, those are hard approaches to come by, but they're working on it. And then there's the response that Rafi's just highlighted, which is in other autoimmune conditions, this idea of, more surgical approaches is just not possible, but we've realized that mild chronic immunotherapy can work and for the most part is safe. So we're kind of caught between those two worlds. I will tell you, for instance, we've been slow to the TNF alpha blockade effort in type 1 diabetes, but Janssen just ran a new onset study. And if you give it for 1 year, the honeymoon looks beautiful. And the question is, are we ready to embrace that as a standard therapy in type 1 or not? And yeah, I don't think the company is continuing that effort. Unfortunately, the data looks beautiful. So yeah, we'll see.
I'd like to just add one more very mysterious aspect of a lot of these therapies. So if you treat patients, say, inflammatory bowel disease with TNF, but you can also treat patients. So from that you might conclude, well, TNF is the critical mediator in some of these autoimmune diseases. You get the same thing with things that are inflammatory. But you can also treat patients with anti-1 and get just as good a response, and the TNF is still there.
Yeah.
So there's this very confusing mystery. Jim, I don't know if you have anything to add to that.
No, I'm with Sandrine on it, and I kind of puzzle about it all the time. Well,
we have a few questions from the Zoom audience. The first, I'm actually going to rephrase a little bit because I had the same question in a broader sense, and that is, are there any particular characteristics of the non-responders? The question here actually asks, are any of them obese? But I'm wondering, like, are there other things if you see in the non-responders, if you go like, oh yeah, that's different from the responders?
Yeah, it's interesting. I think most of what I showed was the aggregate response in these studies, but there's a lot of heterogeneity in response, and there's a lot of heterogeneity in type 1 diabetes. So most of these studies here, we're enrolling a pretty broad age range. I mean, some of them are like 8 to 45. And the nature of the immune response we're learning is very different in type 1 diabetes. So you could pick any age group, if it's 40-year-olds, you might see some of them, who are just observed over time. Some of them may have a very nice long honeymoon, and some of them may show more precipitous decline in beta cell function. So I think it's early days in us knowing what's driving those factors pre-diagnosis and post-diagnosis. In general, age really does drive it. So younger kids lose faster than adults. But I think we're still a little bit of a loss to know what are the immune features below that. So here's the interesting rub. So if you asked all the investigators as we were running that prevention trial, who would respond best to Teplizumab? Those who had poor beta cell function entering the trial, or those who had really robust beta cell function? How many would vote for those with a robust beta cell function as having the best outcome? There was a range of beta cell function coming in. I mean, we would all thought, you're higher up on the curve, so you have more to preserve, and that would be great. If you had less there, you responded better. So that might be some surrogate measure of just a more active immune process. So I think what we're starting to note, at least in some of these studies, is children may do better, and entering studies like this earlier in the disease course may be better. We often push our enrollment out to, say, 3 months from diagnosis, just because it's hard to have these research discussions with families with new onset disease. And yet, if we could get them right when they're in the hospital, shortly after they come out of diabetic ketoacidosis, maybe we'd see better responses. Yeah, I'll also just say, there are some sense of the nature of the difference in the immune response. So those who are younger tend to have more antibodies. They tend to have more of a B cell infiltration of their islets, and adults tend to have fewer antibodies and a little different distribution of T cells in their peripheral circulation. So some interesting difference in characteristics. So it's a sophisticated question without an easy answer.
Go ahead.
Do you have an idea of the safety of frequency of administration? How close together can you give these? Can you give like potentially longer acting forms of it that will stick around for a while and see if that has a more durable effect?
Can you repeat the question?
Yeah, so the question is, do we know how frequently we could redose with this particular medication? Aside from what I showed you, either at once 6 months later or once 12 months later, we haven't explored that further. That exhausted CD8 cell signature seems to wane, somewhere between 6 to 12 months after the prior dose. There's been discussion about whether we use more of a personalized approach. Can we just look for any given individual and think about an ideal window to come in, either with a shift in that immune readout or a shift in their beta cell function. But aside from that, we haven't really explored it. Not that we couldn't or shouldn't. And I think there's also thoughts that maybe this is a good induction therapy, and then we try and come in with some kind of maintenance therapy, whether it be like an antigen-based therapy. Maybe that would work better under the cover of initial inductive therapy with something like this. Or maybe another cytokine therapy like interleukin-2 gets a lot of attention as a way to support regulatory T cells. So we're thinking about a variety of approaches for that.
We are over time, but there's one more question, and it's from Srinath Sanda, who says, sorry, I couldn't be there in person, great talk. But what do you think the long process we experience with the Teplizumab can teach us about how to accelerate this process for other immune modulators?
Yeah, I'm not quite sure, Srinath, if you were referencing like in other drug discovery, how to accelerate the
Approval process.
yes. Yeah, I think, the decisions as you're getting ready to launch trials, it's not like in the lab where you can try it once and realize, oh, I could redesign that better. I mean, you have very few shots on goal, and this could have missed and just been thrown away and discarded very easily. So I think being very careful about the power calculation, what the endpoints are. There's certain factors you can't control, like COVID, which certainly impacted a lot of immunotherapy trials. So yeah, it gives you pause. I don't have an easy answer, but I hope I learn as much as I can from the experience. Thank you all for your attention.
Thank you.